thyroid hormones T3 and T4 play a critical role in the organogenesis and cell differentiation in the developmental stage, and then for the homeostasis, metabolic homeostasis and thermogenesis in the later life. Around 1 in 4,000 infants are born with congenital hypothyroidism, and around 2% of the pregnant women present with subclinical hypothyroidism, and 1 in 500 present with overt hypothyroidism. There are several factors affecting the thyroid function during pregnancy. One is the increased HCG, which mainly stimulates the TSH receptors. The second is the estrogen-induced TBG, which increases the T3 and T4. Then next is the immunological factors, which either alleviate or induce or exacerbate the pre-existing autoimmune thyroid problem. Then the other thing is increase the placental type 3 deadenase, which increase the metabolism of T3 and T4. Next is increase the iron excretion through urine during the pregnant state, which decreases the T3 and T4. So there are several input factors in pregnancy. I think Dr. Jabbar will be a good person. He doesn't need any much introduction. He is a well-known endocrinologist. He is the principal and HOD of the endocrinology of Medical College Trivandrum. I invite Dr. Jabbar for his talk. Please, Jabbar, the stage is yours.
Good evening, my friends. Respected chair, senior members of the profession, my good friend Dr. Kamath sir, my student Dr. Sunny, and senior physicians in Ernakulam, ladies and gentlemen, I'm extremely happy to come to this place because probably seniors knows the relation between me and Kochi. Before giving the talk, disclaimer, nothing to disclose. Number two, special thanks to Dr. Gilles and his team for the kind invitation. My topic is a little broad, but don't get upset. I will stop once the allotted time is over. The plan of action, these are the 4 questions I should answer if possible. One is management of thyrotoxicosis. Which drug? That's the most important concern for our physicians. Hypothyroidism, what are the targets? How to plan for pregnancy after radioactive iodine, especially after Graves treatment. And importance of pre-hormones. Probably I can answer the last question now. If you see what's happening in pregnancy, if I'm quoting words of my teachers, if possible, don't investigate during pregnancy. If possible, don't investigate the patient during pregnancy and critical illness. These are the classical teaching in our general medicine. But if you are doing it, lot of physiological alteration can happen in pregnancy. Please remember, I got lot of reference. Probably I became a practitioner in Kottayam only because of my friends. They are asking for investigation, difficult to interpret, and they want to get an opinion. So please remember, physiological alteration is very, very enormous. And what is happening here is, you have placenta. Placenta, there is a portion known as syncytial trophoblast. These syncytial trophoblasts will produce HCG. HCG and TSH, they are having structural homology. So what will happen? HCG is more, so TSH will come down. So if you get a TSH suppression especially during first trimester, or twins, or triplets, see, don't get upset. That could be a physiological alteration. So what I want to tell you that HCG is increased like this, and TSH is coming down. And TBG, or thyroid binding globulin, is also increased. Why? Because of the effect of estradiol or estrogen. So you have a TBG like this, and very interestingly, T4 goes up initially, and subsequently that will come down. So I will answer the last point. What is the importance of pre-hormone? Pre-hormone assay, theoretically, if the setup is very good, you can ask for pre-hormone. Please remember, in our laboratory, when my teacher R.V. Jayakumar sir and Murali sir was students, those days people were sending samples from here to postgraduate institute of Chandigarh. You understood? So now everywhere, even Murkan Kada, these investigations are available. So please remember, so you have to have a good standard laboratory to perform all this investigation, FT4 and FT3. Just remember, forget about that. If the situation is not there or lab is not perfect to perform pre-hormones, you can just go for T4 also. Only thing, sir, during pregnancy, max 50% elevation is possible. So minimal elevation of T4 is acceptable. Suppression of TSH is also acceptable in pregnancy. Please remember all these important facts. Now we'll go through the case. Very common case. Today also I have seen one interesting case. You have a patient age you can see there, and patient is having persistent vomiting in a first trimester of pregnancy. That could be simple hyperemesis, or this could be a Graves' disease. These are the two immediate differential diagnoses that contest. You can ask for any symptomatology. They may give positive or negative answer, and eventually you will ask for thyroid hormone profile. For this patient, T3 is elevated, T4 is elevated, TSH is suppressed. What is the diagnosis? Fortunately, postgraduates are sitting in the back. So, Sudhemar sir paranya mairi, I don't want to ask questions to consultants, okay? So, you have two differential diagnoses at this moment. What are the differential diagnoses? One, this could be a simple physiological alteration and hyperemesis gravidarum-like situation, which is a benign condition, self-limiting condition. Or this could be a Graves' disease, which is manifesting only now. How to differentiate? These are the ways by which you can differentiate. Hyperemesis gravidarum or gestational thyrotoxicosis, usually very mild symptom except vomiting, no goiter, no ophthalmopathy, no dermopathy, and they can have biochemistry suggestive of Graves' disease. Extremely difficult to differentiate between these two, but the time will tell you after 20 weeks your thyrotoxicosis will settle. That indicates you are dealing with a gestational thyrotoxicosis. So what are the investigations you can look for to differentiate between these two? Of course, laboratory is not really useful. Clinical profile is useful, but you can ask for thyroid receptor antibodies. Also, if it is positive, yes, you can relax. If it is negative, you don't know where we stand. My dear friends, what I want to tell you that investigation should be very, very carefully asked for. It's very important to differentiate. What is the role of radioactive iodine study or technetium scan? For heaven's sake, don't do that. Very important. Always do not ask for radiopharmaceutical studies. This happen, and that court is the case is in the High Court. Please. Now we have another simple investigation which may differentiate between these two conditions. One is Doppler of the inferior thyroid artery. If it is very significant, so radiologists who are sitting here, it's not a foolproof investigation, but radiologists can give an idea that, okay, this seems to be hyperthyroidism, it's not thyrotoxicosis, because the velocity is significantly higher in case of Graves' disease, not in gestational thyroiditis. Now, let me ask four important questions. When to treat, why to treat, which drug, how long, and what is the effect of on fetus? All cases you need not treat. All cases you need not treat. There are certain situations you should treat. Suppose, see what is happening here is the uterus is accommodating a foreign body, in fact. right? Okay, and eventually that will suppress the immune system. So if you have Graves' disease, probably you can see a remission also there. So these are the area we have to be very careful, because giving a toxic drug in pregnancy nowadays, because of lot of YouTube messages and all, you may be in fix sometimes, because people are asking a lot of questions to second, third, fourth opinion. So we have to be very careful. If you have thyroid receptor antibody positivity, that indicates you are having Graves' disease. And in certain situation, if no ophthalmopathy and up to the requirement is very small, like 5 max 10 milligrams of carbimazole, no ophthalmopathy, no dermopathy, no goiter, patient has already taken sufficient time for taking the tablet also. Such a situation, probably treatment is not indicated. If the patient is having persistent symptom, you have to go for treatment. Which drug we'll discuss. This is a gentleman who discovered anti-thyroid drug, Edwin Bennett Asford. So these are the two molecules available here, PTU and carbimazole. These are the difference between these two molecules. But practically, what you should remember is carbimazole will cross the placental barrier to a significant degree. That's a message. And see, what is the effect on the fetus? Affect the fetus, n number of adverse effects is possible. All system, nervous system, cutaneous system, heart system, musculoskeletal system. But compared to methimazole or carbimazole, the PTU effect is not very significant. You can see all these slides, and that's the reason American Thyroid Association coming with a final statement. If patient is becoming pregnant on carbimazole, you should shift to propyl thiouracil, at least for the first trimester. These are the words from the American Thyroid Association. But if I'm quoting words of my own teacher, what he taught me that, say, yes, you can give, provided patients are ready to accept, and they should understand that there are complications with both these drugs. So these are the complications of methimazole or PTU. And finally, my statement is first trimester pregnancy, PTU is a treatment. But don't think that PTU is absolutely stable. We have a case happened in Trivandrum Medical College, my dear friends. Hepatic failure is possible with the PTU, even with a smallest possible dose, it's possible. If we have a patient, a real patient came to gastroenterology medical ward with a history of some sort of abdominal symptoms, and patient went in for delirium and coma. And final diagnosis was thyrotoxicosis on PTU, and patient developed hepatic failure. And for this patient, it was very, very difficult to resuscitate the patient. Finally, we took the patient with a lot of medication, dexamethasone, lithium, propranolol, cholestyramine. Her thyroid function was not improving. We took the patient for hemofiltration also. But fortunately, the thyroid function came down to normal, but unfortunately, patient died, because hepatic failure with PTU is not a joke. This can kill the patient. So we have to be very careful. And the final message should be PTU is not a good drug to use. Exactly, that's the reason all the professional organization giving advice and black box warning. Do not start PT for all patients. Only in the first trimester of pregnancy, you can start PTU. And now you have a patient, the ideal drug is PTU in the first trimester, second and third trimester you can go for carbimazole or methimazole. And how to monitor this patient? Monitoring is, don't look into TSH. TSH is not at all useful. Just go for FT4 or T4, you should maintain to high normal level. That's a management. And the second investigation is TSH receptor antibody. And if patient has got positive antibody, positive positive antibody, you should look for fetal goiter. There are a lot of clinical implications for that. And lastly, when to stop, or is it possible to stop treatment during pregnancy? Now, when to ask for antibodies? So, early pregnancy, certain situations, antithyroid drugs, grace on antithyroid drugs and radioactive iodine treatment, yes, you should go for TSH receptor antibodies. Whereas, if patient is absolutely fine just prior to pregnancy, there is no need. If it is negative, that's fine. And between 18 and 22nd week, to assess the chance for fetal thyrotoxicosis, you should look for thyroid receptor antibody. And to predict the chance for the neonatal thyrotoxicosis, you should perform thyroid receptor antibody between 30 to 34 weeks. And see, if the antibodies are very, very positive, more than 3 times elevation, anticipate and look for evidence of fetal thyrotoxicosis. Fetal in utero, it's possible because fetal medicine is becoming a very good specialty. Even in Trivandrum Medical College, we are giving a proposal to start fetal medicine. So, is it possible to stop antithyroid? It's a really challenging issue, but so there are differences of opinion also. But those who are on very small dose of carbimazole, antibodies are not detected. Normalization of TSH, that indicates patients are good candidates for medical treatment, and duration of treatment more than 6 months. In such a situation, the last weeks of pregnancy, you can stop it. But I have little different opinion. Probably it's not safe also. That's the reason I'm not stopping, but my teachers are stopping treatment also. But if the patient goes for recurrence again during pregnancy, especially at time, that will be headaches. That's the reason I'm not stopping. So we have another patient. I wanted to give a message that the monitoring is very important. You have a patient. This patient is from Kollam. Patient is taking Neomycin. Patient was taking treatment for thyrotoxicosis. Of course, not monitored, and patient came with a little abdominal symptoms and a goiter. So that could be a drug-induced goiter development, and investigation showed evidence of hypothyroidism as evidenced by a TSH of 31.2, and we did an ultrasonogram. Ultrasonogram showed evidence of fetal goiter. If fetal goiter is there are 2 possibilities. This could be in a setting of thyrotoxicosis. This could be a fetal thyrotoxicosis or fetal hypothyroidism. Difficult, but there are certain pointers by which you can differentiate these two. And eventually, the best method is to look for maternal thyroid status. If maternal thyroid status is hypo, that indicates probably your fetus is also having hypothyroidism. If the maternal status is thyrotoxicosis, the chance for fetal thyrotoxicosis is very high. Please remember, don't go for a lot of investigation. Simple clinical assessment will tell you the final diagnosis. And what's the treatment? Simply you stop it. These are the recommendations available here. Please remember, I repeat, in the first trimester of pregnancy, as the recommendation stands, you change to neomycin or methimazole, the smallest possible dose to maintain your FT4 or T4 to high normal level. And there are professional recommendation also. Either you go for PT or carbimazole as by American College of Obstetrician and Gynecologist. But don't get upset. These are the recommendation, but you can continue to give carbimazole also if the patient is very good. These are the recommendation by Indian Thyroid Society. I'm also part of this advisory committee for that. Whatever recommendation we have discussed, one that is shown in these slides also. My dear friends, next topic is hypothyroidism. I don't want to discuss all the topics here, but very importantly, the normative data is different. That's an important point I want to tell you. In first trimester, second trimester, and the last trimester, the normative data is different. If normative data is not known, or you don't have your normative data, just take a figure 2.5 TSH up to 2.5 micro international units in the first trimester, and 3 in the second and last trimester also 3 micro international units per ml. But we have different values detected in our department also, which I'll be discussing probably in the next conference. Now, you have an interesting case. You have a patient with the hypothyroidism, very commonly happening in our medical OPDs and medical colleges. Your TSH is 10 micro international units. First question, is it indication for termination? Very important. Please take a message. Abortion is or MTP is not needed for such type of patients, especially patient conceived spontaneously. There is no indication for going for abortion. So you can give extra dose of thyroxine and try to maintain your TSH level to a normal level, which is defined as less than 2.5 is ideal, and third and second trimester 3 micro international units, that's okay. And you have recommendation from ITS also. ITS also giving a recommendation more or less same, but they are giving little allowance. Up to 4 is also acceptable. But mind you, if you are getting 2.5, my recommendation is better to maintain like that. Always you should look for evidence of autoimmunity as evidenced by a TPO, which gives lot of information regarding the prediction of premature labor, miscarriage, lot of other gynecological issues also. These are the recommendation. Final topic for me, radioactive iodine. When do you want to go for conceivement or pregnancy? Very simple take-home message is just wait for 6 months. Nothing will happen. After 6 months, nothing will happen. But suppose a scene comes, doctor, I became pregnant. Nothing to worry, nothing will happen also. But in theoretically and practically and in the court of law, wait for 6 months before conceiving this patient. Otherwise, lot of complications have been described and documented in the literature, like miscarriage and preterm issues. And these are the meta-analysis. Finally, the take-home message is radioactive treatment. Took radioactive iodine treatment, wait for 6 months to avoid all those complications. Ladies and gentlemen, my dear friends, seniors, what I did was management of thyrotoxicosis in pregnancy. I'm repeating the same sentence. First trimester PTU, second trimester carbimazole, and try to maintain FT4 at high normal level. Please remember to monitor the baby also. Please remember. And hypothyroidism, I already discussed about the target also. And final word regarding radioactive iodine treatment, don't get upset. Wait for 6 months. That's all from me. Thank you so much for the kind attention.
Sir, it was an excellent presentation. I would like to know what incremental dosage of thyroxine we will give to a known case of hypothyroidism.
Madam, see, I didn't get the first sentence. What?
Additional dosage.
Very good. Super. Okay, suppose you have a patient. Patient is coming with a hypothyroidism, as evidenced by TSH of 10 in our patient. Just go for 50, because pregnancy, we presume that young patient, less than 40 or less than 45, chance for coronary is very less. You go for 50% extra. Some books says you go for 2 tablets per week. So what I feel, 50% extra, that's enough. And don't leave the patients monitoring also. Just go for TSH assay again after 4 weeks. Or max you can go for 6 weeks. And try to maintain your TSH to a target level.
Next is a first detected case in first trimester. If the TSH level is near normal, upper level, what should we do?
Very good question. See, the topic selected was probably Gilles is having some grades with me. That's the reason he selected a very vast topic for me. I could not finish everything. That's true. But high normal level, please remember, look for evidence of autoimmunity. We already discussed ATP. If ATP is, we presume that ATP is positive, what will do? That's a common problem for gynecologist. ATP is normal, even if TSH is normal, Negro et al. Comes with a very important advice, euthyroxine. Negro's paper, Valuc's paper is also available for that. But I feel antibodies try to maintain very good TSH, less than 2.5, very good. And even if the TSH is normal, I don't have any situation to say that I will treat. And regarding, there are other controversial areas also. Steroids for antibodies. As the thing stands, it's not needed. But there are a couple of papers saying that steroid treatment is useful. I know our friends in gynecology department, obstetric department, they're all giving steroids for a short time. There is no harm. But the problem is, every week, every month you are repeating ATPO. That is, I don't think there is no scientific rationale for that. Okay, next.
A pregnant lady comes with palpitation and the thyroid function test is found to be high, around the hyperthyroidism, and ultrasound showed thyroiditis. So how to manage thyroiditis in pregnancy with mild hyperthyroidism?
Very good question. See, thyroiditis. So autoimmune thyroid disease. You are talking about low thyroid or hyperthyroid?
Hyperthyroidism.
Hyperthyroid.
High.
Okay. Hyperthyroid, for understanding sake, is thyrotoxicosis. Antibody is positive or negative, that is immaterial. You go for treatment of thyrotoxicosis by whatever molecules we have. All right? Hypothyroidism, yes, there are certain complexities. Thyrotoxicosis, antibody positive or negative, don't bother, you go for treatment. Next question.
Thank you, Dr. Jabbar, for fantastic presentation. I have just one question. You mentioned about hypothyroidism. At what frequency should we monitor TSH for correction of adjusting the drugs? Frequency of monitoring of TSH.
You are talking about hypothyroidism.
Hypo, yeah.
Hypothyroidism, will discuss a non-pregnant patient. 6 to 8 weeks, okay. But pregnancy, pregnancy is an emergency as far as thyroid disease is concerned. So every 4 weeks you can go for. But if you have documented absolutely normal or target TSH, probably next investigation you can delay it. So answer is 4 weeks.
So one more question I have.
You can ask any question, any number of questions.
No, even in a non-pregnant state, we generally prefer to keep the TSH in the first half of the normal range in hypothyroidism, isn't it so?
And planning for pregnancy.
Even
Not planning for pregnancy.
okay, no, even otherwise also, even non-pregnant adults also, don't we keep TSH in the first half of normal range with medicines?
It's a good question. See, depends upon many factors. Suppose my grandmother comes with the TSH of 10. I don't want to treat. Suppose my mother comes with the TSH of 10. I don't want to treat. Suppose my daughter comes with the TSH. Probably I'll treat. Especially in presence of goiter, antibody positive, rising titer, unexplained hyperlipidemia, unexplained hypothyroidism, unexplained depression, I will treat. Then what's the target? Target is normal target. Unlike pregnancy, non-pregnancy, you just go for midway between normal. See, in our hospital, in Trivandrum Medical College and Diabetic Institute, we are having a range of 4. So in such a situation, between 2 and 4, that's okay. But another confusion comes, you have thyroid malignancy, papillary carcinoma. Papillary carcinoma, the TSH target is totally different depending upon the risk stratification. If the patient is coming to a category of high risk, the value should be very strict control to a 2.00. But if it is low risk, just below normal or subnormal. So answer for your question is depends upon multiple issues. Now what will happen, we have seen cases, your age is 50 plus or 60 plus, such a situation your bones also very weak. And osteoporosis is one of the totally neglected area. So if you are using sub or supraphysiological dose of thyroxine, chance for acceleration of osteoporosis is very high. And coronary, what is happening with your coronary? The last Thursday, one of the very active gentleman, administrative officer, came to my office. Trivandrum Medical College principalന്റെ വലിയ പൊക്കത്തായിരിക്കുന്നത്. കയറി വന്ന ഒരു കുഴപ്പമില്ല. He's having only one complaint. Sir, എൻ്റെ നെഞ്ചിൽ എന്തോ ഒരു സാധനം എടുത്തു കളയണം. That's all. That's only complaint. നെഞ്ചിൽ എന്തോ കയറിയിരിക്കുന്നു, ഒന്ന് എടുത്തു കളയണം. എന്ത് ചെയ്യണം? That type of symptomatology, very young, is IAS officer. So you don't know what's happening with the coronary. So don't play with your thyroxine if not indicated. So it's a beautiful topic if you can include misuse of thyroxine next time. Baad mein.
Any questions from the audience?
Sir, there's a doubt. Sir, in the front.
Aradu?
Sir, may I please clarify with you? So, in case of a pregnant woman with anti-TPO antibodies, regardless of her TSH, we should start treatment for her, right? Okay. So, how should we titrate the levels of her treatment if we're not done?
See, this is only Negro's paper. Okay, we presume that as a patient is pregnant or planning for pregnancy, ATP is positive. Even if, see, your aim should be less than 2.5. Minimal elevation also should be treated. These are the recommendation by Negro. He is an author in autoimmune thyroid disease and pregnancy.
Okay. Any further questions? Thank you, Dr. Jabbar. It's a fantastic presentation, and thyroid disorder is as such very important in the management of pregnancy, and because implications are two lives, mother as well as the fetus, and you've done marvelously well. Thank you so much.
Thank you so much.